Hello, everyone. Welcome to the STARR Coalition. We're really excited about today's webinar. As usual, this is your webinar. So in a bit, after Natasha gets through presenting, we really want to open up the floor for all you guys to share your stories, to offer advice, to ask questions. But I'm excited about this topic today. It's a really unique and important subject, and it's very close to my heart. I've been fortunate enough to work with individuals who have many with treatment-resistant mental illness over the years, and I know that trauma is weaved tightly into their narratives. So I'm excited about the subject matter today. Just to kind of start out, statistics show that 9 out of 10 individuals who are diagnosed with a mental illness have endured some form of trauma. And for many of you, I realize this is already information that some of you know because we have docs on the call and some other professionals. So this may just be a little bit of a refresher. But although initially the talk of trauma-informed care really came out due to some discussions around the PTSD studies that are currently taking place out there, really creating that trauma-sensitive environment, that space for all of those diagnosed with a brain disorder. In fact, really, it's great for anyone who comes into a research setting to have some of these core principles kind of set in place. I can imagine, it's got to be very stressful and a very unfamiliar place for people to come in to a research facility. So I think that some of these techniques, I hope, will create a much more comfortable environment for folks. So I'm proud to have with us today a dear friend of mine and an extraordinary clinician. And I do understand that we do not perform therapeutic services in the research environment. So again, the guidelines that we're going to talk about today, hopefully will just kind of create that trauma-sensitive space, a place where people can build trust and a place where it is inviting and comfortable for people to be. So another thing we want to stress is these techniques really need to be shared from your janitorial staff to your nurses and docs, anyone who comes in direct contact with individuals who are there to be a part of a research trial should know these techniques, and it should really be baked into the culture and the operation. So again, I know a lot of you guys already know a lot of these things, but hopefully it'll be something that you can take some stuff away. So let me introduce to you a dear friend of mine, Natasha Dill. She's a licensed clinical social worker. She's worked with individuals living with trauma for over 15 years. Ms. Dill's early career focused on adults with dual diagnosis, and it's a really challenging population because these particular individuals were experiencing symptoms of mental illness, but they also struggled with trauma and trying to rationalize things because they had developmental disabilities as well. Very unique population. But today, Natasha uses all that trauma-informed care model to assist pediatric medical trauma stress and post-traumatic stress symptoms in patients and in families at the Arkansas Children's Hospital here in Little Rock, Arkansas. The model has played a significant role in creating a trauma-sensitive environment for children who've been abused or neglected. She's also used this in evidence-based interventions to prevent re-traumatization. And Natasha really believes that when organizations do create a foundation based on trauma-sensitive interactions with those living with mental illness, that trust that we talked about can be established and engagement is enhanced. And we hope that within our circles and research that we can really create a place where people want to participate and want to be a part of the research that they're participating in. So I don't want to waste any more time yipping and yapping because I'm really excited about Natasha joining us today. So I'm going to turn it over to Natasha. When she gets done, we are going to open up for the last at least 20 to 30 minutes where we can share some stories and talk about our own experiences in this area. So I'm going to turn it over to you, Natasha. Thank you so much for being here today.
Thank you for having me, and thank you for that wonderful introduction. That made me feel really good. So yes, when we were talking about this, when Luke and I were talking about doing this presentation, I was trying to articulate how trauma-informed settings and trauma-informed care is really the water that I swim in daily. Like, I'm coming to you from my office on the cardiovascular ICU unit of a children's hospital, and so ICUs are just trauma incubators for the most part. And so this is really stuff that I kind of live and breathe every day, and I'm really excited to get to share this with you. So we'll get started. There we go. I understand that this is going to be some review. I heard him say that, some of you are doctors and clinicians yourselves, but we'll just start with the basics of what is trauma and what does it do to a person. So a traumatic event is either a single experience or a cumulative reoccurring of experiences that just completely overwhelm an individual's ability to integrate it into their lives, to the executive functioning, to cope or to make sense of what is happening to them. It can come from physical abuse, domestic violence, sexual abuse, anybody that was in a position of authority, so the institutional abuse, neglect. I also want to add medical trauma to that list that's on your screen right now, because that is something that the research is growing quite a bit in, not only for patients, but people that have to watch, like caregivers of patients experiencing post-traumatic symptoms from their hospitalization. A person who's been through a trauma, the hallmarks, the behavioral hallmarks of it are a sense of powerlessness, a fear of being in situations where they lose power, a feeling of hopelessness and helplessness. We use the term hypervigilant, just kind of always on guard, always looking over your shoulder, very sensitive to loud noises or stimulating things. And so in many ways, when we're going to talk about these trauma responses, I want us to frame it that they are ultimately, these are adaptive. Our brains and our bodies are brilliant. They protect us from completely short-circuiting in the event of a trauma that is overwhelming us. And so it protects it, it breaks things up, it only lets us handle a little bit at a time. And how we process that, how we're able to express it, how we're able to work through those chaotic and painful feelings in the years to come, that is actually resilience. And so I really want us to think about that. That's the setting for trauma-informed care, is being able to recognize that the behavioral hallmarks of PTSD, that this is actually how we frame it. They're symbols of survival. The underlying just basic principle of trauma-informed settings, trauma-informed care, is to just assume that everyone you meet, every person that you come into contact with, has had some trauma in their life. I don't know if you are familiar with the ACE study, the Adverse Childhood Event research project. It's basically a scoring, it's a quiz that you take that shows you kind of like you get a point for if you were physically abused. You get a point if somebody in the house was suffering from a severe mental illness while you were a child. And you go through this, and based on those scores, they have correlated that with significant health outcomes in adult populations later on down the road. So high ACE scores are correlated with higher rates of cancer, higher rates of heart disease. I think the last estimate was that it negatively impacts over 60% of adults. And so having just an ACE score of 4, like that doesn't sound like a huge thing. 4 is my ACE score, actually. That increases the risk of emphysema for adults by nearly 400% over somebody that only has one adverse child event. It increases the risk of suicide by over 12,000% over somebody with only one or no ACE event. So the research has now grown that if you have one ACE event, you are 80% more likely to have 2 or more. So that cumulative trauma, that compounded trauma. If you're not familiar with it, I would really suggest Googling it up and taking the ACE score or the ACE quiz yourself. It's really enlightening and helps kind of grasp the vastness of the problem that we're talking about. So being trauma sensitive, it all goes back to being aware and monitoring, giving a sense of safety by allowing people as much control as they can possibly have over their environment. So when you think about research volunteers coming into a research facility, for us in the healthcare world, it's just standard. There's nothing scary about it. It's the place where we hold authority, we hold the knowledge, and we're used to the setting. But for some survivors, for a lot of survivors, healthcare environments, just the fact of being inside them can trigger some of that feeling, those feelings of powerlessness and that feeling of being overwhelmed. It's not even necessarily that anybody has done anything, but just the setting itself puts them at risk. So I've got parents that tell me, parents of patients at the hospital, that tell me that even coming back to the hospital for like a clinic visit or something like that, that they get surprised because, I'm sorry, I'm just gonna do that. They get surprised because something as small as like washing their hands, the smell of the hand soap reminds them, it takes them back to that place where they were in the hospital watching their child on life support or preparing to die. And so, you know, environmental triggers like that. And obviously, to do a trauma-informed setting, you can't control for everything. But I think what we're going to talk about a lot is that they are people in that situation, people experiencing those feelings of being overwhelmed, aren't able to, it shuts down the executive functioning. So they're not able to articulate what it is that they need. And so we have to ask. That's the key. It's the mindset of being aware, monitoring, and asking and giving power as much as possible to the people that we work with. So building on that, not just the environment itself, but an interaction that somebody has might bring up the dynamic that made them feel as horrible as they felt in that moment, something that just reminds them a phrase, a word, a tone of voice, a situation in which they don't have control can trigger those overwhelming feelings and reactions. It can be obvious, or it can be something completely out of the blue that you would never think of. It's usually unintentional, hopefully, it's always unintentional. But we know that intent does not necessarily prevent harm. So good intentions do not protect people from harm. So trauma-informed settings take that, and we can talk about some of the physical markers, like I started to talk about the hand soap, and there are definitely some things just in general. You can ensure that participants aren't asked to be in a very tightly enclosed space with only one other staff member. You can ensure that you're seating people where they can easily see a door, they can access and exit if they need. Just like talking about the hand soap, with asking parents, like in clinic, if I've got a kid who's going to get readmitted, crisis is over, they're just here for clinic, and maybe we just need to monitor them for a couple of days or something like that. But I often ask parents, kind of, okay, what are the triggers going to be? How can we navigate? How can we change the neural pathways by literally changing the physical path? And that could be as simple as, we're going to use a different hospital entrance than we used back then. I'm going to come to the unit via a different hallway, or I'm going to, please don't put my child in room 18, because 18 is, one of the worst nights of my life. So there are some physical markers, but again, there's not a standard physical marker. It's all individualized. And so trauma-informed settings are way more about a mindset and an ethos than the physicality. They seek to anticipate and counterbalance those hallmarks of post-traumatic stress that we've talked about, the hypervigilance, helplessness, a sense of hopelessness, fear. And in treatment settings, what that means, aside from constantly being aware and monitoring, it means giving people, I've said it a million times and I'll say it again, giving people as much control as you possibly can. In healthcare, that means extensive education. It means informed consent practices that meet the patient and the family's needs over just clicking, checking off a checklist that makes it legal. It means as much transparency in the process as possible. So it's really an overall mindset that helps lead to like a questioning attitude and a supportive attitude, more so than it is, a list of tips of, make sure that the lights are at this level of, or have pleasant music playing in the background, that kind of stuff. So nearly half of people with PTSD have experienced something called sanctuary trauma. So what that means is that the place that was supposed to keep them safe, the behavioral health hospital, the group home, the foster care system, in that situation, they experienced additional trauma. And 91% experienced full sanctuary harm, meaning that a staff member was highly insensitive or inappropriate or neglectful or abusive, and that produced or exacerbated symptoms from the trauma before. So these facts, again, speak to the vastness of this problem and how we have to consider it in almost every single interaction that we have in a medical setting. I mean, in life too, but in a medical setting for sure. So transference and countertransference, these are things that we all do. We all experience it. Transference is when an individual takes something unresolved from their past thoughts and feelings and beliefs, and they project it into the current situation. It's cliche. It's a society cliche, right? Like daddy issues. And so what that means when somebody says that, that's shorthand for saying, oh, it's a girl who's working through feelings about her neglectful or abusive dad through the partners that she dates. And so we already know what transference is. Countertransference is where we get into some trouble, because that's from the power dynamic, that's coming from the healthcare provider. It's coming from the researcher. It's coming from the doctor, from the clinician. And so countertransference, it's the same dynamic. It's the same unresolved stuff back there that comes to play, that gets projected into situations. And really the only answer for it, aside from going to therapy, which I think everybody should go to therapy, but the only answer for it is a constant willingness to self-examine, to interrogate your own patterns, and to be aware of what's being projected onto you. And that really helps, like when I'm teaching interns here at the hospital, and, you know, they go in to a patient family room and, you know, come out and they're like, oh, that parent, they hated me. They were so rude. They like told me to get out and this kind of stuff. And helping them understand that it's not about them, the intern, it is that they are interacting with somebody on one of the worst days of their life. Like they're in the hospital with their kid being told this really intense stuff. And so they're bringing all their own unresolved stuff to that situation. And it's not about you. It helps really detach, being aware of transference and countertransference. In trauma-informed settings, what you want to do is present your own nonverbal language, communicate nonverbally that you are relaxed, that you're safe, you're non-aggressive, you're not an aggressive person, that you're interested, and that you're confident. So from your end, I mean, like you don't ever want a heart surgeon that appears nervous when he's doing his informed consent routine with you, right? Like if he's fidgety or constantly kind of looking over his shoulder or very tensed up, that doesn't inspire a sense of safety. So on our part, any interaction that we have with the public, with the outfacing, with the clients, patients, participants, whatever, you want to communicate nonverbally that you believe in what you're doing and you believe that it's safe and that you are relaxed and that you are a warm and welcoming person to be speaking with. From the flip side, in a trauma-informed setting, you want to, again, going back to just being aware, monitoring things. You want to monitor the body language of the participants or your patients or your clients, noticing when there's tension, noticing when there's congruence between what they're saying and what they're doing, and when there's incongruence, because a lot of times that indicates that there's something going on. And those are just triggers. Those are just like paying attention. That's just a moment where then you can adopt a questioning attitude of asking them what is going on and what you might be able to do to help. When I first started, where I met Luke, where he was talking about the first job that I had as a mental health clinician, one of the biggest lessons that I ever learned, and it stays with me, I use it all the time and I use it in teaching as well, is that when helping somebody who's in crisis, don't say you're okay or you're safe or you're fine, everything's going to be okay. I can't tell you how much that is it's an instinct. We want to do that. We want to say that to abused children in our ER. We want to say that to parents of kids who are back having heart surgery. We want to just assure them, it's okay, you're fine, you're safe. That doesn't encourage anybody. That doesn't make anybody feel safe. And so the trauma-informed setting really, one of the things that I think the motto that would be over the door to the hallway of the trauma-informed setting guru, whatever, it would change the language from what's wrong with you, from this medical model, what's wrong with you, or telling you what you are or how you can be fine or how you're not fine, and switching that thought to what happened to you. And instead of telling somebody it's okay, you're fine, you're safe, asking what would make you feel more comfortable or safe right now in this moment? What can I do to help you feel like what do you think might help you calm down? That was a really key switch in my brain. And I think that is what we're talking about when we're talking about using language in a trauma-informed setting. So important to, just like when we started off talking about viewing those behavioral hallmarks as actual signs of a survivor, not a victim, but somebody who survived and lived through a really traumatic experience, and they're still here to this day trying to figure it out. Asking if there are certain ways that, certain words that people don't want to hear, certain phrases, if asking people what they prefer to be called. Sometimes you call somebody by the name that's on the chart, right? And that's the name that their abuser called them, and they don't want to go by that name, so they go by a nickname. Just things like that, things that there's no way to predict or know. It's all about this attitude of questioning, respect, giving people power. And so in whatever position that we're in, like in my job as a social worker up here, and your job as a doctor or a nurse or a research facilitator, the goal is to not re-traumatize. The goal is to do no harm. Like, you know, that's the big at the top. So to not re-traumatize volunteers through negligence, ignorance, or insensitive interactions. To encourage a trusting environment, informed consent, lots of transparency, making sure that they get to a point where they feel like they've got all the information that they need, even if that means going back through it over and over again. Up here, we have a saying that it takes 2 or 3 times to really absorb bad news. And so when we break something hard or sad or challenging to a family, we know that tomorrow we're going to come back and have to say some of the same things over again because the brain has just blocked what it can't process. So it takes a little while to get through to make sure that they truly feel like they're giving informed consent, that they truly feel that they understand everything that's going on. We already talked about asking questions of how you can make people more comfortable. Would you feel more comfortable sitting by the window? Would you feel more comfortable if we adjusted the temperature? Simple stuff like that. And now we're getting to the questions. So I don't know, Luke, if you want to start taking feedback at this point, or you want me to read through these and then we can pause for discussion?
Yeah, read through those real quick, and then then we'll pause and open it up for discussion, please.
Okay. So questions for reflection today are, how willing are you to share control with your research volunteers or the people that you interface with? How do you ensure that the volunteers have received what they feel is adequate information about research processes? What are your own personal boundaries? That gets into that transference and countertransference from before, knowing where your own limits are and the areas that you're going to be sticky. Could any of my actions be seen as boundary violations by the volunteer or the participant? How do you balance the needs, the demands of your job with the need to take adequate time with each person? How are they scheduled? Are you booked solid where you're having to rush through things, or do you have time to truly engage and connect? What might get in the way of communicating my respect for the volunteer? That gets into a lot of implicit bias work as well. What is my own personal style of interacting with volunteers? Does it seem to foster rapport? Do I put effort into that, maintaining that rapport with each volunteer over time? So those are some of the questions that we want you to be thinking of, exploring as we open it up for talking.
You had mentioned a couple of examples too, Natasha, of how you've been able to use some of these techniques to help individuals. And I'll share one real quick. Years ago, when we did work together with a young lady with dual diagnosis, she was very short, very small, sweet young lady, and she would help me out in some of the groups and programmatic stuff I would do at this organization. But I knew that she had a trauma history. I did not know the specifics of her trauma, but I am about 6'2". I'm a big guy, but I was always very conscious about my physical location to her. I could try to physically make myself smaller, how I would use my voice, and I would be sure that I would never put my hand on her shoulder or ever, make any physical contact. Whereas maybe some other individuals I know would love to have a handshake or a hug or a high five. But I was always very aware that I didn't want to do anything at any point that may have kind of put back on what we see as re-traumatization or do something to make her feel uncomfortable. And the other thing is always asking questions. Are you comfortable in here? Would you like to keep the door open? Do you feel comfortable? And always making sure that control was in her hands. So that was a valuable lesson I learned then, mostly with that young lady. So anyone else have any thoughts or stories or questions they want to share? So maybe with that point, Natasha, within research of having that balance between trauma-informed care approach and minimizing that placebo effect or moving over into kind of that therapeutic circle. I mean, how, ways of balancing that. Any thoughts about that at all?
Yeah, I tried to be very mindful of that and thinking about, just creating a setting, not necessarily doing interventions. But yeah, I'm so embedded in the therapeutic nature of it. I'm having a hard time thinking of specific examples. I think the main thing is when you have a trauma-informed setting, when you have a safe setting, that's not doing anything to create new things. It's just preventing old stuff from getting in the way, I guess. It's just leveling the field. So it's not necessarily that it's a therapeutic intervention in and of itself. It's just keeping that stuff from becoming a problem, I guess, is the way I'm.
What you mentioned earlier too, yeah, people coming in and already being apprehensive about being in a healthcare setting, whether it be in a research study or at a hospital at your doctor's office, that the engagement that you have with staff at that point, even from nurses to doctors, it doesn't have to influence your a placebo response as much as it does is just feel that comfort and engagement when they come into the door, that they do have control over their environment, and that they would feel comfortable if they were going into a heart disease study or an oncology study, right? That you want to feel, like you said, is that people are smiling, they're engaged, they're listening, they're paying attention, that they are, asking a lot of questions. And those type of things, I think, are just a natural thing we want to produce in our environment all the time, whether or not, so in any type of setting at all.
Yeah, I mean, I want to go to a dentist that has trauma-informed setting. Like I want all my healthcare situations to be trauma-informed. Not necessarily because it's a traumatic experience to go to the dentist, but just because it's a stressful, anxiety-provoking. Mm-hmm. So even having a setting like that, even if you do have one of those lucky, 1 out of 10 adults that didn't have a history of trauma, it's still good for them too. Like it still sets the stage for whatever it is that you're there to work on.
Also kind of stressed too at the beginning, Natasha, about the importance of all staff having some of this information, right? I mean, in over the years, I'm sure you've seen it can be it might be that receptionist that brings that person back in for the next time. Maybe they're just dispositioned in such a way that they feel comfortable, and that may be the person. It may not be the doc or the other people within that circle. It could be anyone that they have contact with. So how important is it that trauma-informed care, some of these principles, are integrated into all of the staff?
Oh, absolutely. I mean, still, I'm coming from a medical team perspective, but I mentioned implicit bias too, because that's another area that I think requires this like constant awareness and this constant discussion. It's not just an ongoing where you do a CEU and check it off. It's something that you're evaluating all the time. And so like our clinic staff, being able to talk with not just the doctor, but the echo tech and the person who comes to draw labs about, this kid is very sensitive to touch or things like that, or just not touching without permission kind of thing, letting somebody know that you're about to touch them and why you're doing it. So yeah, I mean, it's at all levels, definitely. And it's something that, like I said, you can't plan for every little aspect. You can't possibly control an environment to fit everybody's needs on the front end. And so it's just nurturing this culture of awareness and questioning kind of thing. So having leaders on board is number one important, but all the way through the team.
I think it's fortunate to have people, like you said, at the very top, who realizes that creating a trauma-sensitive environment is important for the way they operate to us. But a couple of things I'll just announce is if for those of you who are STARR certified, for those of you who are STARR certified sites, we have just created a new module for trauma-informed care that we'll be sending out to everyone to include in the manual that they have for the STARR certification. We're also working on another module too, diversity in clinical research. We've got an incredible group of advocates and researchers from across the industry, and we are putting together a really thorough diversity in clinical research module and some information. And a lot of it, there's several different parts of diversity in clinical research, but the first thing is going to be focused on sites. What are some things that we have found from working with you guys already and other sites that have really helped increase not only the diversity within the site itself, but also how are we reaching out to all of our communities with which we serve, and then in what ways are we doing it? Is it culturally appropriate? Are there some things that we can do to help maybe and do it in a very thoughtful, sensitive way? Another thing too, we relaunched about 2 or 3 weeks ago, Eric, I think it was, our national call to action for clinical research. This has been an ongoing project for about a little over a year. We have worked with, again, great industry leaders, great advocates on how can we talk about clinical research in our communities, but number two, what are actionable ways that we can actually push the needle a bit on brain health research? And so the techniques are pretty easy, simple to do, but focus a lot around from information and education on the volunteer side, all the way to supporting public policy, helping fund cutting edge research, a couple of different areas. And we're going to be continually releasing some of that information over the next several months. But please be a part of our national call to action for clinical research. You can just go to our website at thestarr.org, and immediately there'll be a pop-up that you can sign up for. Also, tomorrow starts the Mental Health Awareness Month. So we hope that all of you will participate in some way, whether it be through social media, through your website, any way that you can talk about the importance of mental health awareness. I know that several of you have got interviews set up with local media, or have written letters to the editor, or try to do some things, some outward approaching ways to talk about mental health awareness. If you go to our website again, you go to the top and you'll see a resource tab, click under that, and we have a lot of information that you can pull, share. There are graphics, statistics, websites, links that you can take. So please take those and share them through your platforms as well. So we've got a lot of exciting things going on right now. All right. Well, again, thank you, Natasha. I appreciate you being here today. It's always a pleasure to be with you. And I know that you've got, again, a lot of experience in trauma-informed care. I may be reaching out to you if people have any specific questions. So I do appreciate your time with us today. And, and thank you, Erica, for getting all this coordinated and getting us up and running today. And again, if you guys want to know more information, please run over to our website at thestarr.org and sign up for our national call to action. Get ready for Mental Health Awareness Month starting tomorrow. Become STARR certified. We got a lot of great things going on right now. So please be a part of what we're doing. And remember that you guys are the STARR Coalition. You're the smart ones. We just try to bring you all together to solve some complex issues that is affecting what we see is some incredible research that's happening right now. So thank you for your time. And again, thank you, Natasha, and everyone have a wonderful weekend.